And the first speaker is Dr. Varsha. Is she here? Yeah.
A very good morning to all. I'll be talking about our paper on post-operative visual loss following orbital surgeries, a 24-year experience at a tertiary eye care center. Vision loss following orbital surgery is the single most dreaded complication of any surgeon or a patient, and it has significant medical legal implications as well as psychological and socio-economical implications. Our objective was to study the risk factors, clinical, radiological, pathological profile, and management outcomes in postoperative visual loss following orbital surgeries at a tertiary eye care center. It is a retrospective interventional case series. Patients with postoperative visual loss following orbital surgery over a period of 20 years from 2000 to 2024 were included in the study. The outcome measures were demographic data, clinical presentations, radiological features, pathological profile, causes, and the visual outcomes. A total of 22 cases were included in the study. The mean age was 43 years. The majority of the cases were following a tumor removal surgery, which amounts to 63% of the cases. This was followed by fracture repair with 14%. Coming to the incidence of POVL, following tumor removal surgery, the incidence of postoperative visual loss was 1.77%, whereas following orbital decompression and fracture repair was 1.06 and 0.56%. All the tumors were located in the intraconal space, and the most common location was the temporal to the optic nerve. 6 cases of intraconal tumors were located temporal to the optic nerve, which had POVL. Histopathology proved that majority of the cases, almost up to 50%, were schwannomas. This was followed by cavernous hemangioma, which was noted in 14% of the cases, 22% of the cases. The causes of the POVL was also assessed. 64% of the cases had central retinal artery occlusion, and 23%, 5 in number, was attributed to compressive optic neuropathy. Ophthalmic artery occlusion, ischemic optic neuropathy, and direct injury to the optic nerve was seen in one patient each. The preoperative vision was normal, 6.6 in 63.6% of the patients, whereas the rest had a preoperative drop in vision. Immediate post-op vision on the same day, about 2 to 3 hours after the surgery, was noted, and no PL was noted in 15 cases, which amounts to 68.2% of the cases, and the drop in vision ranged from no PL and to 2/60. The treatment which was given was IVMP 1 gram 3 doses immediately after the surgery on the first post-op day, as well as followed by the next 2 days, and oral steroids. One patient had undergone an implant removal as the compressive optic neuropathy was attributed to the implant position. 59.1% of cases remained no PL, and these were all CRAOs, whereas 5 cases luckily had improvement in vision, which amounted to 22.7%. Surprisingly, 2 of them were no PL postoperatively, and both had improved to 6.6 vision with grossly restricted field effect but a small temporal island of vision. In comparison to the other studies, the POL incidence after tumor removal in our case series is 1.77%, which is comparatively lesser than other studies. The incidence followed by the fracture repair was, however, slightly higher compared to some of them. So our study, the POVL was seen maximum after the tumor removal surgery, which was inconsistent with other studies by Dr. Rose et al. Permanent blindness again was noted in 59.7% of our cases, and this was inconsistent with the other findings of the study, other studies. Partial recovery was noted in 22.7% of cases with prompt treatment. In conclusion, intracorneal lesions located temporal to the optic nerve pose a higher risk for POVL. Retinal artery occlusion is the most common cause of visual loss. Close monitoring and urgent management may improve visual outcome. Patients with compressive optic neuropathy fare better after prompt treatment. These are my references. Thank you.
Thank you, Dr. It's a good study. Uh, how many cases were the intraconal, rather near the optic nerve or surrounding the optic nerve,
All the
who are
cases were
having, total number of cases, and
Yes.
out of whom how many cases you told 22?
22 cases with a total number of cases.
Yeah.
So tumor removal was in 14 cases, sir.
So all 14,
All 14 were intracorneal lesions. They were excisional biopsies.
so all they have the visual loss?
Yes, these 14 cases were all intracorneal lesions. So the total number of cases over the period of 24 years was 790 patients, total number.
Then one more finding you told that some two cases were having PL,
Yes.
no PL
Yes,
before,
yes.
and after that they removed.
Yes,
So
surprisingly.
what was the reason?
So the one case was a fracture repair patient where the implant was positioned. This was a post FES done patient elsewhere, wherein the debridement of orbital tissue was inadvertently done with the debrider possibly. So there was no intracorneal fat surrounding the optic nerve in the quadrant. So when we had placed the mesh, immediately in the ICU, when we had assessed the vision, it was no PLs. We had removed the implant and again administered IVMP in the vision required. The other patient was again a fracture repair, which was done endoscopically, wherein there was no reason for compressive optic neuropathy. So ischemic optic neuropathy was the possible diagnosis. This particular child had even developed an XT, for which, because of the severe drop in vision, and then because he had regained a little bit of island of vision, surprisingly, the squint correction was also done, and he had a gross field effect, but still he has 6/6 vision. So these were the two cases which we were quite surprised that though the patient has no PL, amazingly they recovered, and the one patient was actually a
I
medical
think
rep.
they
So
must
it
have
was
done
extremely stressful.
very quickly. Surgery must have done very quickly after.
Yes,
The,
the implant removal had done the same day. It was actually my
Thank you.
patients had
Thank
done
you.
it the
Thank you
same
so
day.
much.
Thank you.
Just one more thing. It seems all the intracorneal tumor had lost vision.
No, ma'am. The total number of cases included in the study was 790 patients, and in that, 14 patients had lost vision. So our incidence is actually 1.77%.
Of vision loss.
Yeah,
And
yes.
why? How you explain the central retinal artery occlusion?
Central retinal artery occlusion or ophthalmic artery occlusion was quite a clear-cut diagnosis clinically. Fundus photograph and FFA was also done. So differentiation between CRAO and ophthalmic artery occlusion was done with the help of FFA.
No, etiology.
Etiology was a clinical diagnosis when they had cherry red spot and pale retina on examination for the CRAO part of it. But for the compressive optic neuropathy is more of an attribution. We cannot really distinguish ischemic and compressive optic neuropathy with only clinical and investigations. Possible diagnosis, ma'am.
Okay, thank you.
Thank you.
Next speaker is Dr. Anurit Kaur. Yeah, please.
Good morning, one and all. I'll be presenting a case series on orbital dermoid with discharging fistula. So we all know that dermoids can either be superficial or deep. Superficial dermoids are diagnosed early. However, deeper dermoids are inconspicuous in nature and they lead to misdiagnosis and usually are detected late. So if deep dermoids remain dormant normally, so when do they actually present? In case of trauma or infection, there is rupture of the cyst which forms a tract and the tract epithelializes and there is a formation of permanent fistula. So our study was a retrospective observational study carried from 2019 to 2022 and patients with orbital dermoid along with fistula were recruited and they were studied for presenting features, management and treatment outcomes. The average age was 18.4 years. With out of total 28 orbital dermoid patients, 5 of them presented with fistula, accounting for 17.8%. Out of them, 60% were male and had right eye as the most involved eye. Duration of symptoms ranged from 1.5 weeks to 8 years, with 8 years being the most chronic one. And treatment was, orbitotomy was done for all the patients with complete removal of fistula. We even used trypan blue as an adjunct for identifying the fistula and removing them completely. The mean follow-up period was 2 years and no recurrence was noted. So I'll be presenting the cases. So case number 1 was misdiagnosed previously as congenital nasolacrimal duct obstruction. These pictures were taken by the father, and the pictures show puckering near the lateral canthal of the eye. And this patient was previously misdiagnosed as CNLDO, and when she came to us, we did imaging, and finally it was a dermoid with fistula, and she was treated successfully. A 30-year-old female, she had a previous episode of redness, discharging fistula and swelling. Similar episode happened 12 years back. She was diagnosed as tubercular granuloma and even received ATT. When she presented to us, on table we used trypan blue as an adjunct to basically delineate the epithelial lining of the fistula so that complete removal could be done. This is the post-operative picture of the patient with no recurrence. A 14-year-old male presented with pus discharge on lateral side of the right eye for 8 years. So he presented with multiple previous surgeries done elsewhere, and he was suspected to be a cholesteatoma case. Intraoperatively, we went ahead with the orbitotomy, and the fistula was basically intraosseous, and it was extending till the zygomatic arch. So there was we did complete removal of the orbital dermoid along with the fistula. There were 2 fistular openings which were noted. One was near the lateral canthus and one was a bit superior to it. So we used Bowman's probe to delineate the fistula, and both the fistula were completely removed. This is the post-operative picture of the patient. This is another case with multiple fistular opening, one near the lateral canthus and one near the brow that we can see, and we removed it completely with no recurrence noted. So on review of literature, there have been cases where orbital deep dermoids have been, they were so lately diagnosed that they even led to chronic osteomyelitis, and few of the cases have been reported as meningitis. One of the patient, one case report from Nigeria showed that because of lack of care, after 2 years, the child had to undergo exentration. So our study is basically considerably the largest case series in Indian subcontinent. We used adjuncts like trypan blue, and glue was also used, cyanoacrylate glue, and it led to complete removal. Therefore, there were no recurrences. So in conclusion, if there is chronic periocular cicatricial process, if we see any teething, any fistula, any retraction, we have to rule out underlying dermoid. In case of isolated discharging fistula, it can be a tip of the iceberg, and we have to evaluate all the cases radiologically. Complete excision of cyst and fistula is of paramount importance, and we can use adjunctives like trypan blue and cyanoacrylate glue. Thank you.
It's a good presentation, but I would like to ask you some questions. How do you differentiate between congenital nasolacrimal duct obstruction and tis fistula?
Ma'am, basically this was referred from outside. So this patient for around 2-3 months, previously it was diagnosed as congenital because they were presenting with swelling and discharging, like pus discharge was there. Also this child had another opening in cul-de-sac also. So they were thinking that this is CNLDO, but once they presented, we did radiological imaging, and it was actually a dermoid was sitting there.
No. What radiological imaging you have done?
Ma'am, CT. CT.
Only CT.
CT.
Have you tried syringing in this case?
Ma'am, syringing was tried. That was normal. Like patient underwent syringing and probing. That was normal.
Okay.
Yeah.
Then any other contrast studies you have done?
Counter study.
No. Is there and the third case, gyrgoma, is there any intercranial extension was there?
No, ma'am.
No. Okay.
Thank you.
Okay, thank you, Dr. So we should go to the next speaker, Dr. P. Monica.
morning. I am Dr. Monica presenting COVID-19 associated rhino-orbital and rhino-orbitocerebral mucormycosis. Let's navigate into the complexities. Mucormycosis is a fatal fungal infection and it is a non-contagious disease which spreads by spore inhalation. Pathogenically, it's under 3 stages like angioinvasive, vessel thrombosis, tissue necrosis, and it occurs in 2 forms like rhino-orbital mucormycosis and rhino-orbitocerebral mucormycosis. We did a retrospective observational study over a period of 1 year during 2023 from Jan to December, during which we have comprehensively analyzed the diversity of presentation, management, prognosis in COVID-19 associated mucormycosis at a tertiary eye care hospital. A total of 69 cases were reported during this 1 year period, out of which 47.8% were rhino-orbitocerebral mucormycosis and 52.1% were rhino-orbital mucormycosis cases. And this is a pathological slide which represents the angioinvasive nature of the organism, where we can see the fungal hyphae within the lumen of the vessel and also within the wall of the vessel. Around 62.5% of the patients presented with no light perception during their first visit under the group of rhino-orbitocerebral mucormycosis. We had a varied diversity of presentations of these patients, starting from the conjunctiva to the retina, and there was almost an equal number of ptosis presentation in both the groups, and a higher percentage of presentation of patients with proptosis at around 31.8% in rhino-orbitocerebral mucormycosis group and 18.8% of lagophthalmus in rhino-orbitocerebral mucormycosis group, and there was around 37.5% of central retinal artery occlusion in the patients with rhino-orbitocerebral mucormycosis. In cornea, we had neurotrophic ulcers, exposure keratopathies, and neuro-ophthalmologically patients had orbital apex syndromes, optic neuropathy, and in retina, as we have seen, central retinal artery and vein occlusions were seen. These are few photographic representations of patients who presented to us. They had complete ptosis, neurotrophic ulcers, and dystopia. The patients were treated with 47.8% were treated with posaconazole and 52.2% received liposomal amphotericin B. These are the various procedures our patients underwent, like they underwent orbital decompression, debridement, maxillectomy, and excenteration. A higher percentage of patients under rhino-orbitocerebral mucormycosis group underwent debridement. Around 28.1% of recurrence has been noted in a group of rhino-orbitocerebral mucormycosis group, and there was a higher percentage of ocular morbidity seen in rhino-orbital mucormycosis group, which was around 8.1%. These are the various specialty requirements which our patients required during their initial visit. Almost an equal percentage of 75.7% in rhino-orbital mucormycosis group and 71.9% in rhino-orbitocerebral mucormycosis group required orbit clinic evaluation. These are the multi-speciality referrals which our patients required in their subsequent visits, and majority have developed invasive fungal sinusitis in their subsequent visits and required ENT clinic evaluation. So, in coming to the discussion, in the post-COVID era, a considerate rise was noted in neuro-ophthalmological manifestations and also cornea conditions. And as mucormycosis is an aggressive disease, an inadequate treatment might lead to progression of the disease from rhino-orbital to rhino-orbitocerebral mucormycosis over a period of time. So, early diagnosis and multidisciplinary approach is crucial for and life-saving to the patient. A periodic follow-up and comprehensive care is needed in all these patients. During this period, reconstructive procedures and rehabilitation was done in all of these patients, along with which our patients, we have created awareness how important was the follow-up during the post-COVID period. So the key message, COVID-19 has contributed to a surge in mucormycosis cases leading to severe ophthalmological and neurological complications. A timely and multidisciplinary intervention is crucial in improving the patient outcomes and reducing the morbidity. These are my references, and thank you.
Thank you. I think this was a very memorable time for most of the oculoplastic surgeons at that time. So, thank you for reminding those days again. It's a good series, but what is your observation regarding the feeling of gratitude by the patient to save the life and doing exenteration or debridement, whatever? Have some feedback. Just I want to know because we all of have came across with all these things.
Sir, actually, even in post-COVID era, like patient had manifestations in their ocular conditions. So few patients have come only for rehabilitation, and because it's like at least the spread was cessated, the patients were happy that they are alive.
See, one point is that though we suffered COVID, the COVID phase is right now over. So, regarding ocular these findings, what do you want to suggest? What was the etiology actually?
Ma'am,
In COVID
actually,
patient.
because they have developed diabetes and their immunity was suppressed, and we were not able to combat the infection, even though we have started aggressive managements. It's like recurrently periodic follow-ups and comprehensive care was needed in these patients. So creating awareness was also important, and they were still coming for lots of follow-ups till date. Few patients like.
And the next question is that why did they develop diabetes most of the cases? This is a very interesting
Steroid usage.
Exactly. And one more thing, okay, you have one more paper on orbital macromycosis, so I'm not going to comment right now. There are some points to be added. So, in fact, I wanted some take-home message from you.
I just wanted, like, even the COVID has been subsided, even in the post-COVID era, public should be aware of the consequences. Yes,
Okay, thank you so much.
thank you, sir.
Our next speaker is Dr. Jalak Sirmoy.
Dr. Priyanka, no?
Jalak Sirmoy. Right.
Dr.
Adult contract.
Jalak Shimoy?
She's there, sir.
Huh?
She's already there. She has come.
So good morning all. I will be presenting a case series of adult contracted sockets treated with serial conformers. So we all know that microphthalmos is a condition where eyes are abnormally small with at least an axial length of at least 2 standard deviation below the mean for age. We can classify it again as simple and complex microphthalmia, like complex wherein you have some microorbitism or conditions like that. And according to Gopal Krishna classification, we know that grade 1 is where the inferior fornix is shallow, and grade 2 is where the inferior and the superior fornix is shallow. So in our study, we have included cases up to grade 2 contracted sockets. So when it comes to management of microphthalmia, it is actually age dependent. When a pediatric age patient comes, we always say that earlier, start the expansion at the earliest. But whatever is the age group, it's usually a good teamwork is needed between the ophthalmologist, ocularist, and a very supportive family. So aim of treating any microphthalmic socket is to rehabilitate the socket in order to allow the retention of a suitable prosthesis and to develop an acceptable and symmetric appearance. So when an adult patient with microphthalmia comes to you with a treatment naive socket, so usually if they have never taken a treatment till now, they are mostly not very willing for surgical intervention. That's when we thought, why not try the serial conformer expansion in adults. So I'll be presenting this case series where desirable socket expansion was achieved with conformer trial alone in adult patients with simple microphthalmia. We have included patients with more than 18 years with microphthalmia with a treatment naive socket up to grade 2 traction. So we know that serial conformer expansion is where you start expanding the socket with most snugly fitting conformer, and slowly over a period of 4 to 6 weeks you increase the size of the conformer till a desirable expansion is achieved. So this is one example of a patient who was 22-year-old. You can see that she has a right microphthalmic socket. We started expanding her socket with an 18 millimeter conformer, and she was followed up at every 4 weeks, and at After 4 months, where we could, you know, we could place a 24 millimeter conformer, we were able to dispense a customized ocular prosthesis for her. So this is her final appearance. So we know that prevalence of anophthalmia and microphthalmia is around 0.2 to 3 per 10,000 births, and literature says early expansion is always recommended. So the basic principle is mechanical stretch stimulus for the tissue growth. So when an adult patient comes to you with some volume or surface loss, what we usually think about is, you know, either replacing with the volume with an implant, and then augment the surface with either MMG or EMG, and or else something like a dermis fat graft. So, but there are observations that microphthalmic eyes have an, you know, potential for growth if the axial length is more than 16 millimeters. So in our study, we have included around 7 patients, and the mean age was like 26 point. It's not moving. Slide is not moving. No. So mean age was 26.28, and the least width was 15 millimeters, and the mean duration for expansion was 4.7 months. So this is the second case. She was again in her late 20s, and this is the at the end of 6 months. So again a patient, he was the oldest patient in our series with 34 he was 34 years, and at the end of 5 months, this was the result. So in conclusion, we can achieve good socket expansion with conformers alone in adults with simple microphthalmia, not associated with any microorbitism or other microphthalmic syndromes. But yeah, limitation is that we have to still follow up, long-term follow-up is still needed to know the further outcomes. Thank you.
Thank you, Dr. Saab. I think we all agree that contracted socket is the most difficult cases in oculoplastics. We all know, and it's a very good series presented by you.
I would like to ask, how you have 100% success rate?
Yeah, in all these 7 patients, yes, we have had. But we have chosen only up to grade 2 contracted sockets, and most of them did not have any other, you know, facial hypoplasia or mid-facial symptoms, nothing.
There should be, I think, some time you have to wait. Then after that, if doesn't work, maybe you have to
so
go
only
for.
in one patient we had to modify the conformer a little bit, like customize the conformer. Others, we were using just the stock conformers.
No, I'm
Only
not asking that. Suppose you are waiting for a period, then
Yeah.
it doesn't work.
2 to 4 weeks, like
Huh.
first follow-up.
Hmm.
Every follow-up is at 4 weeks. So at the first follow, like after 4 weeks, if there's no much expansion, we have tried for one more, like 4 weeks, and if not, yeah.
Go for surgery,
Yeah.
I think. Okay, thank you.
She has purposely taken the grade up to grade 2 only. Okay, thank you. Next speaker is Dr. Deepti Kurian.
Good morning, everybody. My study is on craniofacial fibrous dysplasia, or CFD, a surgical conundrum. So CFD is a rare genetic disorder where normal bony tissue is replaced by fibrosis connective tissue, and this occurs because of a mutation in GNA's gene, and it causes skeletal lesions, skin hyperpigmentation, and endocrinopathies. So the clinical spectrum is actually quite wide. You can have just a mild asymmetry to significant cosmetic disfigurement to, I don't know why this has come like that, to significant proptosis and dystopia causing double vision. And radiological variants can vary from the typical ground glass appearance, sclerotic type, cystic type, and pagetoid variant. We also notice 2 types of anatomical variants, anterior and posterior, and we notice some patients have multiple bone involvement, some have limited disease with a single bone but can have large cystic components causing significant compression. So the best practice guidelines actually tell us to wait and watch, and this was from a consortium of 51 experts over 13 countries. There is some sort of guideline on when to use bisphosphonates, especially when you have multiple fractures on the involved bone, severe pain, or elevated serum bone markers. Surgery is always advised with caution only if there is significant compression causing optic neuropathy and vision loss. So by the sound of it, the guidelines are actually quite gray, and we just wanted to start asking some questions. So especially when you face a patient face to face and they ask you, what are my chances of vision loss? Um, especially when there is a posterior disease. Will I ever need optic canal decompression, and what is the visual prognosis? So the aim of our study was to look at the clinico-radiological features in CFT involving the orbit and look at the visual outcome in those undergoing optic canal decompression. So we had about 22 patients in the last 10 years, and we had a slight male predominance. Mean age was 20 years. And if you look at the second column, surprisingly, about 40 or 44 eyes, that is 90% of patients, actually had 6x6 or 6x9 vision. And four eyes had the other extreme. They had really poor vision, one with no PL, two with hand motions, and one with 6x60. And if you look at the third column, you see that optic canal involvement radiologically was seen in 50% of the cases. So although 50% had canal involvement radiologically, only four eyes had significant vision loss. That was about 9%. So some of the associated features we know are McCune-Albright syndrome, where you have precocious puberty, endocrinopathies, along with fibrous dysplasia. And this happens mostly in children, and this warrants a prompt referral to endocrinologists. In our cohort, observation was done in 10, bisphosphonates were administered in 5, canal decompression was done in 3 patients for 4 eyes with the poor vision. Prophylactic decompression was done in none, as is advised, and bone contouring for cosmesis was done in 6 patients. This was one of the patients with bilateral optic nerve atrophy who underwent endoscopic expanded 3D navigation guided canal decompression, and one of her eyes actually improved. So at a mean follow-up of over 2 years, we found that those with 6x6, 6/9 vision actually remained unchanged. With those with poor vision, the no PLI and the one of the hand motions or PL plus eye remained unchanged. One of the eyes with hand motions actually improved to 1/60, which I wouldn't call significant. One eye with 6/60 actually improved to 6/36, and she actually reported significant subjective improvement. Now, so this is what we actually observed as far as vision was concerned. And this kind of gives us a starting point. Maybe 6/60 is the cutoff, which can be quite sensitive to actually say that there might be some improvement, although our cohort is quite small. Radiological progression or recurrence was seen in 4 patients, close to 20%. And this again fell across all groups. 1 patient who received bisphosphonates, 1 who had surgical decompression, and 2 who had bone contouring. So we're not really able to say if bisphosphonates actually prevent regression or if surgery causes, recurrence of disease. So Lee et al. Actually found that 88% who had radiological bony involvement had no optic neuropathy. This was about 73% in our eyes, which meant even though there was bone involvement, vision remained stable. And even in meta-analysis, they show that 95% who were observed and 75% who had surgery had long-term stable vision. But this still really doesn't answer our questions. What are the factors that predict optic neuropathy? We couldn't draw a conclusion, but we had 2 patients with growth hormone excess, 1 with aneurysmal bone cyst. These are some of the reported factors that can cause progression of disease. I will skip this time due to want of time. So in conclusion, vision is not always affected in case of optic canal disease. Up to 80% can have stable vision even with the radiological involvement of your optic canal, and prophylactic decompression is not advised. Visual prognosis of those who present with poor vision can be guarded. Risk factors for predicting progression or nerve compression is unclear. But if you see a patient with poor vision, especially for future multicentric studies, maybe 6/60 could be a sensitive cutoff where we can closely look at to see if those patients, whether they improve or not. Like I said, we need larger studies to really address this issue to answer our patients' questions better. Thank you. These are my references.
Thank you, Dr. Dipti. Actually, what I was thinking that what are the basic indications for go for surgery? Because you yourself told that optic canal disease does not mean that patient will lose the vision, number one. But what are the other specialists which you would like to involve during the surgery?
I would definitely involve my endoscopic surgeons because I think endoscopic surgery would be a safer approach for these patients. But we know that if a patient presents to you and they have radiological involvement of the canal and poor vision, you tend to offer surgery. But you always caution them that visual improvement is guarded. That cutoff is really not clear in the scientific community. If you have 6/6, do you improve? If you have PL plus, do you improve or not? In our patients with hand movements and less, did not improve, but they didn't lose vision, which is another thing that you're always worried about when you go for optic nerve decompression. So, yeah.
What is your...
But the other thing we have noticed is sometimes we see, like in some of the pictures I showed, there is significant canal narrowing on on the CT, but the vision is actually pretty good. So then we decide to observe. Yes. Yes, you're right.
Yeah.
So we actually did fields for some of the patients, but we didn't have for all 22. It was a smaller number, so I couldn't really analyze it because the numbers were small. But we do recommend do it for all patients.
I can just draw a line from the decompression challenges I face, and a lot of times visual acuity is 20/30. But when you look at the visual field, when you look at the color vision,
Yeah.
and sometimes even the VEP, you tend to know how bad the disease
Yes.
is.
Yeah, that is right. Actually, and I think the indication for surgery could be that if we do serial things, that if it is, we think that it is progressing, then I think it is
Yes, for
advisable for
sure.
the patient to go for the surgery.
And one of my
Because
patients.
the basic thing is that if we cannot do better, at least we cannot do worse.
Correct. So like sir said, feels color vision for sure. And one other thing I would look at is what this patient feels. Like one patient improved from 660 to 3/60, which is on Snellen's is just one line, but she really reported a subjective improvement and she was really happy. So always go by that also.
Okay, thank you, Dr. Deepti.
What procedure normally you do to visualize the optic canal?
So-
Radiological procedure?
CT scan. ma'am.
Only
Just
CT scan
because
or you just want to modify that?
contrast enhanced CT, just
No,
because it
anything
is
else?
smaller cuts to see the optic.
See, CT scan with 3D reconstruction
Okay,
should be better,
Yeah.
isn't it?
Yes, we ask for sagittal and 3D reconstruction in all patients. Thank
Okay,
you.
Thank you.
Dr. Ajit Samuel. Microbial spectrum of eyelid and orbital infections.
It is said that a picture speaks 1,000 words. Now, when we have a child who comes to the OPD with this kind of presentation, which complication is going to be our worst nightmare? And the very reason that we think of such a complication is the impetus for my research topic, microbiological spectrum of eyelid and orbital infections in patients treated at a tertiary hospital in South India. Good morning, I am Dr. Ajit Samuel, and it is my pleasure to be here with you. So my eyelid or orbital infections, if left untreated, can progress to severe complications like cavernous sinus thrombosis and many more. So ideally, these patients would require gram staining followed by culture sensitivity, and so that we have the most effective treatment. However, microbiological tests may not be readily available. So knowing the most common pathogen can help us start the right empirical treatment. My research objective was to identify the most common bacterial or fungal infection or the pathogen and evaluate current empirical antibiotic regimen and suggest updates. This is a descriptive cross-sectional study. All patients with eyelid or orbital infections who needed to undergo pus culture and sensitivity were included in the study over a 1-year period. All 189 patients underwent gram staining and followed by culture on 5% sheep blood agar and antibiotic susceptibility testing. We divided the patients into 2 categories based on age: below 18 years, which accounted for 19%, and above 18 years, which accounted for 81%. And there was an almost equal male to female distribution. Now, this slide tells us the most common infection below 18 years, which was preseptal cellulitis, and most common above 18 years, which was lacrimal sac abscess. Table 1, out of the 189 patients who went gram staining, 116 showed smear positivity. Table 2 shows 189 patients who underwent culture sensitivity, showed 157 showed growth. Table 3 is a comparison between the smear result and the culture result. So out of 116 who had smear positivity, 111 showed culture, and out of the 5 that did not show culture, 4 were gram positive and 1 was gram negative. And out of the 73 which were smear negative, 46 showed culture, which is a huge 63%. This is a broad categorization. The most common gram-positive isolate was Staphylococcus aureus, and the most common gram-negative isolate was Enterobacter species, which was a new finding in this study. Now let's break it down even further. Under 18, the most common gram-positive isolate was Staphylococcus aureus, and the gram-negative isolate was Haemophilus influenzae. And for above 18, it was Coagulase negative Staphylococcus, and for gram-negative, it was Enterobacter species. Now, it is seen that chloramphenicol and cefuroxime was the most sensitive against all the gram-positive bacteria in both under 18, above 18 age group. Special note on fluoroquinolones, which showed round the house least sensitivity except in Streptococcus above 18. So in conclusion for this, we would like to change systemic cefotaxime to systemic cefuroxime. Now for gram-negative bacteria, it is seen that tobramycin, chloramphenicol and polymyxin B were sensitive across the board. Again, fluoroquinolones were least sensitive against Enterobacter species, which we found out to be most in our particular study. So this enforces the current regimen which we follow, which is chloramphenicol, polymyxin B and tobramycin for gram-negative organisms. Previous literature have been done similarly, but these concentrated on singular infections, and also in this study we have shown a drastic shift in fluoroquinolone sensitivity over the years. In conclusion, we found that we only had bacterial isolates from the 189 patients, the most common gram-positive being Staphylococcus aureus, followed by Coagulase negative Staphylococcus, and the most common gram-negative was Enterobacter species. 63% of our smear-negative samples demonstrated growth, which underscores the importance of sending all patients for culture sensitivity despite your gram staining results. The most common, for gram-positive, the most susceptible was chloramphenicol, least sensitive was fluoroquinolones. For gram-negative, it was chloramphenicol with polymyxin B. And one particular change that we would like to propose is for gram-positive infections, parental cefotaxime to be replaced by cefuroxime. Thank you.
Thank you, Dr. Sahab. You are very good study, good number, and I think good message also, because fluoroquinolones they are going on taking on the back seat, and old antibiotics they are coming up. So I think we should take this message.
Yes,
I think it's very good study and good number also.
Thank you, sir.
You only studied on the bacterial part, not fungal part?
We did not have any fungal in these 189 samples, ma'am. So what we usually do is, even on gram staining, you are able to find out if it is a fungal specimen, and then we can go ahead with the KOH and so on, Sebrod's potatoes agar for culture and growth. However, for these 89, we only found bacterial isolates.
Not a single case of fungus.
Not one, which was also very, enlightening for us. But yes, we did not find any fungal for out of these samples that we took.
Have you got any methicillin resistance there for years?
Yes, we did receive some methicillin resistive, but it was also a small proportion. We had 25% of our Staphylococcus being methicillin resistant.
What medication used to work for that?
Vancomycin had to be given for those patients.
Okay,
Yes.
fine. That you should have mentioned actually. Huh?
Okay. Yes.
Regarding sir said, of course, you should always, I think, cut down the fluoroquinolones. It's sometimes like becoming like an over-the-counter medication these days. That's what, sir.
Okay, thank you.
Thank you, sir.
So we'll go to the next speaker, Dr. Monica Gill.
Good morning, everyone. Myself, Dr. Monica. Before proceeding ahead with my topic, firstly, I would like to thank APO and AIOS for giving me this opportunity. The study is to the purpose is to study the effects of flower petal technique of evisceration in young male, which allows the use of large orbital implants and closure without any tension on the wound. This is a case report of 16-year-old young male who came to the eye OPD with right eye enthesis with past history of trauma to right eye in the childhood, and the patient's right eye was eviscerated through flower petal technique, and the orbital implant was put to provide cosmesis as per the patient's requirement and also to prevent the socket contraction. Coming to the ocular examination, so the best corrected visual acuity in right eye was PL negative and in left eye it was 6/6, and the ocular motility was full in both the eyes, whereas the adnexa in right eye have pseudotosis and in left eye it was within normal limit, and the anterior segment conjunctiva was thinned out with narrow fornices, and rest of the details were not appreciable in right eye because of the opaque cornea, and in the left eye it was within normal limit. So the B scan of right eye came out to be within normal limit. Coming to the management, retrobulbar anesthesia and IV sedation was given, and eyelid speculum was placed between the eyelids, and 360-degree conjunctival peritomy was done, and a blunt subtenon dissection with Stevens scissors to expose the retrobulbar area, and cornea with 1 mm of adjacent limbus removed, and all the contents of the eyeball were removed with evisceration scoop. Then 4 sclerotomies were performed from the limbus between the rectus muscle insertions to the optic nerve, and the 4 sclerotomies reach one another to form the 4 separate scleral petals, each containing 1 rectus muscle insertion, and all the 4 flaps were disinserted from the optic nerve by the circumferential incision 3 mm from the optic nerve. So this is the front view of the 4 independent scleral fragment, each attached to the rectus muscle, and the 4 petals are sectioned from the optic nerve, and then the orbital implant is placed inside the 4 petals. So the vertical petals are sutured first over the implant, and the posterior sclerotomies allow the petal to grow in front of the large implant, and the horizontal petals sutured over the vertical one, and this order of suturing allow the 3 different perpendicular planes: vertical petal, horizontal petals, and the Tenon's capsule. So as we can see, this is the sclera with its 4 petals, and here no choroidal tissue left, and then we place the orbital implant, and we first suture the vertical petals, then the horizontal petals. In this patient, we use Mule's PMMA orbital implant with axial length of 20 mm, and during the post-operative follow of 6 months, the patient had good cosmesis, and there was no complaint of implant exposure or migration and contraction of the socket or sympathetic ophthalmia. So coming to the discussion, the orbital implants replace the volume loss of the cavity and preserve motility with good cosmesis and orbital expansion. The eye and soft tissue removal is replaced by implant, 80% volume which is filled by the implant, and rest of the 20% volume filled by the prosthesis. So therefore, orbital implant followed by conformer result in ocular prosthesis, scleral shell. So here comes the different type of implant. First one is non-integrated. So there is no growth of orbital tissue because they are solid and non-porous implants. Example, PMMA, acrylic, and silicone. Another one is integrated. The implant and prosthesis can be fitted together so that the motility of implant is transmitted to the prosthesis, and it provides the better motility. Example, hydroxyapatite, aluminum oxide, etc. Then semi-integrated one, so they have projections facing the anterior surface which can fit into the corresponding grooves in the posterior surface of prosthesis. So they have holes in them through which rectus muscles can be sutured to the implant. Examples are Allen and Schaff. Then bio-integrated, the hydroxyapatite and porous polyethylene implants, they allow the growth of orbital blood vessels and soft tissues into their pores. Biogenic one are the autologous bone or dermis fat grafts, which may also be used as implants. So these are the various type of orbital implants. So coming to the conclusion, so this technique of evisceration is very easy, quick, and with excellent results, and allow the use of orbital implant of desired size, usually 3 mm less than the axial length of the contralateral eye. So it restores the desired orbital volume, including that in the thiatrical eyes, and the double scleral layer also provide additional protection to avoid the implant exposure. Because the fibrovascular ingrowth in the implant begins at the sclerotomies,
no disadvantage to performing an extra sclerotomy, and it preserves the position of all the muscles, giving the socket more natural motility with better cosmesis. So the take-home message is the right choice of surgery with right choice of orbital implant has palliative effect on the well-being of the individuals with the thysis bulbi. So therefore, flower petal technique of evisceration with orbital implant is a boon, especially for young people, to prevent the socket contraction. Thank you.
Thank you, Dr. Monica. What type of implant did you use in your cases?
So porous one PMMA.
PMMA.
Yes, sir.
Any extrusion?
No, sir.
Hmm?
No, sir.
What size?
Sir, 20 mm.
Very unlikely. Very unlikely, because these implants, they have got lot of extrusion.
Yes, sir. There are more chances of.
A lot of extrusion.
Yes, sir.
The silicone implants are better, and the size. Actually, what you told is that 3 mm less than the size. But actually, it is. This is maybe theoretical. If you go to practice of it, I think if you use more than 16 mm implant, most likely it extrudes.
Yes,
Okay, so that is the thing which I wanted to comment to. Thank you.
Thank you, sir.
This is single case or case series?
Yes, ma'am.
Pardon?
Yes, ma'am.
Single case.
Yes, ma'am.
Okay.
Okay.
Our next speaker is Dr. Shashi Tanwar. Dr. Shashi Tanwar present? I think so. Then we'll go to our next speaker, Dr. Shalin Shah.
Yeah,
I think so.
Okay, good morning everyone. So I'll be presenting about a modified incision for inferomedial orbitotomy. So why do we need to approach the inferomedial orbit? So we have certain orbital tumors and lacrimal sac malignancies presenting in the inferior or the inferomedial orbit. Then we have maxillary and ethmoid sinus malignancies who are asymptomatic and they present with proptosis and outward deviation when they invade the orbit. Then we have failed DCR cases probably associated with a large mucocele which are often invading the orbit. And then we have orbitoethmoid fractures which involve the medial wall and the floor of the orbit. So these are our conventional incisions for orbitotomy. Here we have the 4 medial and inferior orbit incisions. 2 of them skin, the Siegel and Lynch incision, and 2 of them perilimbal and transcanalicular incisions. The problem with these are that we don't get enough exposure when we want to approach the posterior orbit, or we need to extend them along the inferior lid to create kind of a swinging lid crease incision to approach the inferior orbit. So we got inspired from our ENT colleagues. This is the classical Weber-Ferguson incision which is used for maxillectomy purposes, where a subciliary 3 mm from the lid margin incision is taken along the lower eyelid and then progressed along the nasolabial fold. So we modified it into a smaller incision exclusively for the inferomedial orbital lesions. And this includes a subciliary component, horizontal part, and a vertical oblique incision along the nasolabial fold. So I'll directly move on to our cases. So this was a prospective study where we included sequential cases of the indications I mentioned before. And so this was a case of a 41-year-old male patient swelling below medial canthus around 3 centimeters on superficial examination, and he had a history of failed external DCR 2 years back. As we can see on imaging, there is pneumatization of the lacrimal bone actually. So it was an agar-nazi cell there, and the DCR surgery was performed where only one of the table of the agar-nazi cell was removed and the other table was not removed. So we can see that the lateral wall of nose, which is pointed with the red arrow, is actually intact. And this led to a large mucocele which was expanding into the orbit, into the medial orbit, displacing the globe upwards. So here we went ahead with an external DCR with a complete mucocele excision using this incision. This was my first case. So here I did not meticulously suture the orbicularis back to the medial canthal tendon, and we can see some amount of tear trough deformity which has formed here. And so in the further cases, we had meticulously anchored the the orbicularis to the medial canthal tendon, which gave a much better cosmetic outcome. So this was again a similar case where an agar-nazi cell mucocele had developed following a failed DCR surgery. And this was the endoscopic view. This patient, we could have an endoscopic view. So adjacent to the axilla, we can see the bulge at the agar-nazi cell. And again, the patient underwent a similar surgery. Now, the second group of cases we took were lacrimal sac malignancies. So again, a middle-aged male patient, failed history of DCR. And this was the imaging where we see an expansile, well-defined lesion which is compressing the globe. On incision biopsy, it came out to be adenocarcinoma of the lacrimal sac. And these are the post-op pictures where a meticulous suturing was done of the orbicularis, and we can see a very good outcome since it was performed a few weeks back. I don't have a long-term follow-up for him. And we have used this even for large orbital lesions. This was a malignant melanoma spreading into the orbit. And this was combined with the ENT person for maxillectomy, superficial maxillectomy. And this is the scar we got after exentration and maxillectomy. Another case of nasoorbital ethmoidal fractures which had spared the nasolacrimal duct and lacrimal sac. So the patient was actually patent on syringing but had enophthalmos with floor and medial wall fracture. And this is the appearance at 3 weeks. We can see a very faint scar at the site of incision, and we could easily place a large Medpor implant in this. And this was one of our very recent cases, a maxillary sinus malignancy invading the orbit. So here again, the similar approach was used for an incision biopsy. And so in conclusion, we get a better exposure and we can save the canaliculi and lacrimal sac except for lacrimal sac malignancies. There is minimal scarring and proper excision. So thank you.
Thank you, Dr. Shaleen. Good approach.
It was done in ophthalmology or ENTOT?
Ma'am, all of these, except the last case, which was a maxillary sinus malignancy, they were done in ophthalmology. We invited our ENT colleagues over.
Especially the one with the tumor, we could have done it with the help of a frontal flap. Exentration with frontal flap could have been done.
Yes, ma'am. So it was around a 75-year-old lady, and we had explained that we could reconstruct it. We even gave her the option of a temporalis muscle flap for the socket reconstruction. But actually the family was not ready for a very large, multiple incisions and multiple site surgery. So they just wanted an exentration, and that's it. Since it was not spreading behind and her PET was fortunately negative, she had no liver mets. So we just did an exentration with maxillectomy, and she's doing fine. We have a 6-month follow-up.
Did you do a frozen section?
Yes, ma'am, we did frozen section, and we had multiple tissue bits taken from the superficial cheek and from the nose and from the forehead just to confirm negative biopsies, and then from the orbital apex as well. And we had negative, then we just closed the skin over the bare bone.
And regarding lacrimal cases, did you use a stent?
No, ma'am. Actually, that patient, we have removed the canaliculi, the inferior canaliculus, the sac and everything. Right now he is awaiting his radiotherapy. And after the radiotherapy, we'll have to plan a conjunctival DCR because the sac and the inferior canaliculus are gone. And on the last visit, the upper canaliculus had developed stenosis because of the post-op scarring. Thank you, ma'am.
Thank you. Now we have two semi-finalists. List have been provided. So we'll call them also. So Dr. Sushant, please.
Shall I begin?
Yeah, please.
A very good morning. So today I'm here with a short presentation titled Eyeing the Impact, Ocular Manifestations of Xeroderma pigmentosum. So as we all know, xeroderma is a rare autosomal recessive DNA repair disorder. It's caused due to damage in DNA due to ultraviolet radiation. And it may have ophthalmic, dermatologic, and neurological manifestations. Kaposi had first coined the term xeroderma to denote characteristic dry and pigmented skin. And as we know, this is a very rare disease with incidence of 1 in 250,000 live births. So there are 8 known subtypes ranging from XPA to G and XPV, which correspond to the 8 genes that affect in this condition. And the genes are usually involved in the nucleotide excision repair, due to which the gene gets damaged and results in all the underlying manifestations. So these clinical manifestations, generally, the patients present with photosensitivity, pigmentary skin changes, UV radiation, induced damage to the eyes, cutaneous tumor development, and progressive neurological degeneration. So our study was conducted in the time frame between 2018 to 2024, and a complete ophthalmic evaluation of all those patients with xeroderma was done. So we could enroll a total of 30 patients with xeroderma. 17 were female and 13 were male patients, and the mean age of presentation was 21.9 years. So for the ease of analysis, we subcategorized these patients into 4 categories, so which we shall be discussing further. So the first category was eyelid abnormalities, and the most common abnormality we could find was ectropion in 4 patients and trichiasis and lid mass in 3 patients each, followed by entropion and synblepharon in 2 patients each. So the next surface abnormality we could find was photophobia, which was the most common presentation in 23 patients, followed by redness, watering, and foreign body sensations. So coming to the ocular surface abnormalities, it was surprising to see that the most common presentation here was ocular surface squamous neoplasia, which was present in 10 out of the 30 patients. Apart from that, we had punctate keratopathy and pterygium, which are the more common presentations. So this was one of our patients with bilateral OSSN. So in the right eye, the surgery was done, and the histopathological evaluation revealed conjunctival intraepithelial neoplasia grade 3, and in the left eye, the patient had invasive squamous cell carcinoma. So in our series, we could find 2 patients with invasive squamous cell carcinoma, and 1 patient had a concurrent nasal bridge squamous cell carcinoma as well. But it was very sad to know that it resulted in death of both these patients as they were lost to follow-up. So this is an interesting case series where we can see there are 5 siblings from the same family, and all of them had xeroderma pigmentosum. The first row shows the presentation in the year 2018, and the second row shows that in 2024. And we can see that the ocular as well as the skin pigmentary changes have increased over time. So this is another case wherein there are 2 siblings from the same family. The first row shows the elder sister, which she had a very dense corneal haze, and the second one is another sister. She had got synblepharon in both her eyes. So 7 out of the 30 patients had sluggish pupils, and 3 out of the 30 patients had abnormal extraocular movements as well. So 2 out of the 30 had some form of cataract, and 1 out of 30 had pigmentary retinal abnormality. So in conclusion, our study found a very large proportion of xeroderma patients with ocular manifestation. So there were almost 93 patients, 93% of the patients had ocular manifestation. So we should always keep in mind that these patients need a regular detailed examination by an ophthalmologist. They need regular use of UV protective sunglasses, use of lubricants on a daily basis, and urgent treatment and referral if any ocular disorders develop. So in contrast to the popular saying that sunlight is good for you, but for xeroderma pigmentosum patients, it's always stay away from sunlight and save your sight. Thank you.
Thank you. It's a good presentation. Any comments?
Genetic counseling of these families?
Yes, ma'am, we have counseled them, but we couldn't perform genetic counseling because in Nepal, the genetic testing is very expensive. For one patient, it takes around 35,000, and it's very, they cannot afford that. But we are planning, if we can arrange some funds, at least for these siblings, we are planning genetic counseling, ma'am. Okay. Sure.
Okay, so thank you. Now we have our last speaker, Dr. Rath. This is
Shruti.
presenting author is Dr. Shruti.
That's
Yes,
right.
thank you. Sir.
It's not moving. A very good morning to one and all. What do we do if a patient presents with severe blepharoptosis with poor levator function and we want to correct it with autogenous tissue with prolonged effect? Yes, you can either go for a frontalis sling with fascia lata or frontalis flap. What is already known, postoperatively, there should be good symmetry in the eyelid height, there should be a good eyelid contour so that the patient is happy, and there should be minimal postoperative lag of thalamus. While most existing studies limit their outcome measures to only eyelid height and lag of thalamus, eyelid contour symmetry with the fellow eyes is vital to the aesthetic appearance of the face. So this led us to compare the outcome of frontalis sling with autogenous fascia lata and frontalis flap surgery in blepharoptosis patients using image J based objective measurements. This was essentially a retrospective review of 41 patients in a decade between 2014 to 2024 done at the LV Prasad Eye Institute, Bhubaneswar. We included 17 normal volunteers representative of all age and gender with no obvious eye asymmetry or eye surgery. So we had 24 patients who had undergone surgery grouped into group A, who comprised 10 patients who underwent fascia lata, and group B, who comprised 14 patients who underwent frontalis flap surgery. All measurements were objectively derived using the image J software. The primary outcome measure was MRD1, the secondary outcome measure was lag of thalamus, and inter-eye nasal bitemporal ratio. Now what do I mean by that? A digital protractor was superimposed on the standard clinical photograph of eye of the patient. An x-axis or a horizontal axis passing through the lateral canthus, and y-axis was passing through the MRD1 or the 90-degree superior limbus. So there was a common central point. From there, at 15-degree intervals, the rays were passed through the upper eyelid to find out the contour of the eyelid. Moving on to the demography, showed that there was a slight male preponderance. The normal volunteers had a mean age of 23.7. The fascia lata group had 17.4 as the mean age, and frontalis flap had 34.7 as the mean age. Both the groups showed significant and comparable improvement in MRD1 post-surgery. Moving on to the contour symmetry. So you can see here that we had actually compared the inter-eye nasal ratio and the inter-eye temporal ratio. We had plotted it on a map. The blue color here shows the mean of the inter-eye nasal ratio, which was plotted for normal, fascia lata and frontalis flap group, while the black line showed the mean of inter-eye nasal ratio, temporal ratio for all the three groups. So it was seen that though the mean was comparable, in the post-operative group, there was a large variation. Lag of thalamus was worse in the frontalis flap in contrast to literature, and revision surgeries was more commonly performed in fascia lata group. So there were a previous few studies which had objectively, mathematically, compared the temporal by nasal ratio and the eyelid contour using mathematical third-degree equations for diseases like Graves' disease and congenital blepharoptosis, though nobody had compared the eyelid symmetry post-surgery for the two most commonly performed surgeries like fascia lata sling and frontalis flap. Though our study was retrospective in design, had a smaller sample size, and assumed that the horizontal corneal diameter was 11.5 millimeters, our study was one of its kind. It objectively measured the eyelid height and contour with image J. It compared eyelid symmetry with normal volunteers, thereby reducing subjective bias in the outcome. Frontalis flap gave comparable height and contour as compared to fascia lata as studied in our group. Lag of thalamus was seen more in frontalis flap group in our study. I thank you so much for your patient listening.
Statistics is a method you used here.
So we had used image J to objectively find out the measurements, and the statistical this thing used was T, the student's T test. So image J is basically a Java-based image processing program which helps us to find out the measurements easily. So this was basically an objective measurement to find out the MRD1 and the contour symmetry between both the eyes.
My question is that you compare with the normal volunteer, or you compare
No,
between
inter-eye, madam. Inter-eye, symmetry.
of same person?
Yeah.
Okay.
Yeah. Because the patients were bothered about the symmetry post-surgery.
So to be clear, the normal volunteer, you said you just compared with the other of the
Yeah,
same
we
person.
wanted age-matched and sex-matched control, so we included a few of them.
Fine.
Thank you.
Okay, so thank you all the speakers and all the delegates who are present here. I'm handing over the session to the next session. Thank you, Dr. Kokali.